quick question. If I told you there was an antipsychotic that FDA approves for both schizophrenia and bipolar depression, barely raises your prolactin, barely moves your weight, and doesn't touch your QTC, would you believe me? Because that drug exists, and it's sitting in your psychiatry syllabus right now. Today we're dissecting Lurasidone, receptor by receptor, milligram by milligram, the Maudsley, the BNF and Stalway. Stay to the end, because the final dosing table covers the food rule, renal and hepatic adjustments and maximum doses, the details that are easiest to miss and most important to get right. So what family does Lurasidone actually belong to? Second generation, yes, but structurally it's a benzisothiazole, the same backbone as ziprasidone. Functionally though, it behaves like the newer, cleaner cousin of risperidone. Same D2/5-HT2A core, but with a much better side effect passport. Hold that thought on cleaner cousin because it's about to explain a lot of what we cover today. Here's the twist that catches people out. In the UK, Lurasidone is licensed for schizophrenia only, adults and adolescents from age 13, cross the Atlantic, and the FDA also licenses it for bipolar 1 depression, alone or added to lithium or valproate. Maudsley actually rates it as a first-line option for bipolar depression where it's tolerated, because of that metabolic profile we're about to unpack, but that's clinical practice guidance, not a UK license. There's also an off-license use worth knowing, augmenting clozapine in treatment-resistant schizophrenia, backed by case series evidence, not a full license. Don't confuse licensed, guideline-recommended, and off-license evidence. They're three different tiers. One mechanism, 4 brain locations, 4 different outcomes, that's the whole story here. D2 antagonism in the mesolimbic pathway is the antipsychotic backbone. It's what switches off positive symptoms. Move to the nigrostriatal pathway, and D2 blockade alone would cause EPS. But 5-HT2A antagonism disinhibits dopamine there too, which is why the EPS profile stays low. In the mesocortical pathway, high-affinity 5-HT7 antagonism is Lurasidone's real signature. That's where the mood, cognitive and sleep effects come from. And it's the reason this drug earns its place in bipolar depression. 5-HT1A partial agonism adds further anxiolytic tone and EPS protection. And right at the pituitary, the tuberoinfundibular pathway, Lurasidone's impact stays minimal, which is why prolactin doesn't climb the way it does with other antipsychotics. Same D2 receptor, different pathway, different job every time. One starting point, 4 completely different destinations. Watch this. Everything begins right here at the midbrain in the VTA and the substantia nigra, where dopamine cell bodies live. Now follow the first line as it travels up toward the nucleus accumbens. That's the mesolimbic pathway, and it's the one we actually want to block. This is where antipsychotic efficacy lives. Next, a line reaches up into the prefrontal cortex, the mesocortical pathway. This is the one tied to mood, motivation, and cognition. Now down to the striatum, the nigrostriatal pathway. This is the movement control circuit, the one responsible for extrapyramidal side effects when it's blocked too hard. And finally, down to the pituitary gland, the tuberoinfundibular pathway. This is the one that governs prolactin release. Same dopamine, same starting point, same receptor, but 4 completely different destinations and 4 completely different jobs. With the receptors that carry the most clinical weight, this table is worth learning properly because it's counterintuitive. Highest affinity isn't D2, it's D4 and 5-HT7 tied at the top, but don't let that trick you into thinking D2 doesn't matter clinically. D2 antagonism is still the non-negotiable requirement for antipsychotic efficacy. It just doesn't need to be the tightest binding receptor to do its job. 5-HT2A sits right alongside it, softening the extrapyramidal burden that pure D2 blockade would cause. And 5-HT1A partial agonism adds an anxiolytic, antidepressant-like tone while further protecting against motor side effects. These 5 receptors are the ones doing almost all of the clinical heavy lifting. Alpha-1 blockade gives you the postural hypotension, and Lurasidone sits right at the bottom of the incidence table for this, under 2%, tied with asenapine as the lowest of any second-generation antipsychotic, compared to 24% with clozapine and 27% with quetiapine. That's a real citable number, not just a vague low-risk label. Alpha-2A and alpha-2C blockade lift noradrenaline and serotonin tone, adding to that antidepressant signal we keep coming back to. D3 blockade works in the mesolimbic pathway, away from the pituitary, which is part of why prolactin stays low, and 5-HT2C weak here, which is exactly why weight doesn't climb the way it does with a drug like olanzapine, where that same receptor is blocked hard. Finally, the bottom of the table, H1 and M1 negligible. Memorize that gap. Lurasidone isn't better with food, it's dependent on it. Take it with at least 350 kilocalories and bioavailability can nearly triple compared with a fasted dose. Skip the meal, and you're not just losing a bit of effect. Absorption becomes genuinely unreliable, which in practice means unpredictable relapse risk if patients aren't told this clearly. Now let's talk about Tmax, because this term gets thrown around without explanation. Tmax simply means time to maximum concentration. It's the point after taking a dose where the drug's level in the blood peaks, before the body starts clearing it faster than it's being absorbed. For Lurasidone, that peak is reached at around 1 to 3 hours after the dose. Why does Tmax matter clinically? 2 reasons. First, it tells you roughly when a patient is likely to feel the drug's effects most strongly, including any dose-related side effects like sedation or nausea, useful for counseling on timing. Second, it's a marker used to judge how quickly a drug is being absorbed. A delayed or unpredictable Tmax, like you'd see if this drug is taken fasted, is a sign that absorption itself has become erratic. First, protein binding. Over 99% of Lurasidone in your bloodstream isn't floating around freely. It's bound to plasma proteins, mainly albumin. That figure, greater than 99%, is worth knowing precisely, because only the unbound, roughly less than -1% fraction is pharmacologically active. That's the part that can actually cross into tissue and exert an effect. So why does this matter? Because if you give a second highly protein-bound drug alongside it, the two molecules compete for the same binding sites. One can displace the other off the protein, suddenly increasing the free, active fraction of one or both drugs. And that's a displacement interaction, a real mechanism worth knowing. Second, half-life. That's simply the time it takes for the plasma concentration of the drug to fall by half. Lurasidone's half-life is around 18 hours. Why does that number matter clinically? 2 reasons. 1, it tells you how often to dose. A half-life this long comfortably supports once-daily dosing because the drug hasn't cleared out before the next dose is due. 2, it tells you how long the drug lingers after you stop it. A half-life like this means it takes roughly 4 to 5 half-lives, so 3 to 4 days, for the drug to be essentially washed out of the system after discontinuation. Third, and this follows directly from half-life, steady state. Every time you take a dose, some of the previous dose is still in your system, so levels build up gradually with each subsequent dose, until the amount going in per day equals the amount being cleared per day. At that point, plasma levels plateau, that's steady state. As a rule of thumb, it takes about 4 to 5 half-lives to get there, which for Lurasidone lands you at roughly a week. Clinically, this is the number that should stop you from judging a dose too early. If a patient isn't showing full effect at day 3, that's not treatment failure, that's just pharmacokinetics. The drug hasn't finished accumulating yet. Last stop, metabolism and excretion. And this is the slide that quietly sets up everything we'll cover in the interactions section later. Lurasidone is metabolized entirely through CYP3A4, producing one active metabolite alongside inactive ones. Because it's a CYP3A4 substrate, not an inhibitor or inducer itself, every interaction you'll see later is really the same story told with a different partner drug. Excretion is mostly fecal, around 80%, with only 9% excreted unchanged in the urine. That fecal dominance is exactly why hepatic impairment needs dose reduction. And that renal component, small but real, is why renal impairment does too. Remember this slide. The interaction slide later is just this concept applied. Pharmacodynamics is just pharmacology with consequences attached. Every receptor from the earlier slides now earns its clinical keep. D2 gives you antipsychotic efficacy, and it's a full antagonist here, not a partial one, which matters because it distinguishes Lurasidone from drugs like aripiprazole or cariprazine that work as D2 partial agonists instead. 5-HT2A is also full antagonism, and it softens the EPS that pure D2 blockade would cause. 5-HT7 again full antagonism is the one doing the heavy lifting for mood, for cognition, for the bipolar depression license. The only receptor on this entire table where Lurasidone acts as a partial agonist rather than a full antagonist is 5-HT1A. That's the anxiolytic, EPS softening one. Every other receptor it touches, it fully blocks. And the two it barely touches at all, H1 and M1, are the reason you don't see the sedation and weight gain that plague olanzapine or quetiapine. Lurasidone is a full antagonist almost everywhere. D2, 5-HT2A, 5-HT7, the alpha receptors D3, 5-HT2C, all fully blocked. There's exactly one exception, 5-HT1A, where it's a partial agonist. That single distinction is what separates this drug's mechanism from the partial agonist antipsychotics like aripiprazole and cariprazine, which work as D2 partial agonists instead of full antagonists. If a question asks you to categorize lurasidone by mechanism, full D2 antagonist is the answer, not partial agonist, which is a different drug family entirely. Dosing questions are free marks if you anchor to one number, 37. That's your starting dose in schizophrenia, titrating to a max of 148. Now here's the twist. Add a moderate CYP3A4 inhibitor like diltiazem or fluconazole, and that starting dose halves to 18.5, capped at 74. But strong inhibitors and inducers aren't a dose adjustment scenario at all. They're contraindicated outright. That distinction, moderate means adjust, strong means don't combine, is exactly the kind of nuance that separates a pass from a borderline fail on a written question. In hepatic impairment, moderate to severe, start at 18.5 mg once daily. In moderate impairment you can still titrate up to 74 mg, but in severe impairment 37 mg is your ceiling. That stepped cap, not a single flat adjustment, is exactly the kind of detail a written question tests. In renal impairment, creatinine clearance under 50, same starting point, 18.5 mg once daily, titrating to a maximum of 74, but if clearance drops below 15, that's not a dosing formula anymore, it's a judgment call. Use only if benefit outweighs risk. Take it with food at least 350 kilocalories every single time in every population. We've covered why already. Without it, absorption becomes unreliable. Evening dosing is often preferred, not because the license demands it, but because it reduces how sedating or motor-heavy the drug feels to the patient the next day. And if you're stopping it, taper over 1 to 2 weeks. Don't stop abruptly. That's a rule that applies to antipsychotics generally, and lurasidone is no exception. Abrupt discontinuation risks rebound psychosis. Before we move to monitoring, let's lock down the contraindications, because this is where written papers like to test absolutes rather than nuance. Hypersensitivity is the obvious one. Strong CYP3A4 inhibitors or inducers, we just covered that. It's a hard stop, not a dose tweak. In pregnancy, use only if benefit outweighs risk, and remember the class-wide warning that applies to every antipsychotic, not just this one. Third trimester exposure carries a risk of neonatal extrapyramidal symptoms or withdrawal. In breastfeeding, same principle, benefit must outweigh risk, and it's present in milk in animal studies. Now here's a genuinely high-yield negative fact. Lurasidone is not licensed for dementia-related psychosis in the elderly, and it carries the same increased mortality warning that applies across the entire antipsychotic class in this population, mainly cardiovascular and infectious causes. And in children, the UK license only extends to 13 and over, for schizophrenia specifically, nothing younger, nothing broader. Monitoring for lurasidone is really standard antipsychotic monitoring, dialed down where the evidence allows it. You still do the full metabolic panel, weight, glucose, lipids, because good practice doesn't bend to one drug's reputation, but you can be reassured on ECG. Maudsley places it in the no-effect group. There is one curious trial finding worth knowing precisely. QTC lengthened by 7.5 milliseconds at 120 mg, but only 4.6 milliseconds at the much higher 600 mg dose, a genuinely non-dose related pattern, which is exactly the sort of oddity that makes it into a question stem. Where I'd want you to pause is LFTs and renal function. Dosing itself changes with hepatic and renal impairment, so monitoring those organs isn't optional, it's dose determining. And don't forget the practical point, driving advice given sedation risk on an individual basis. In trial data, QTC lengthened by 7.5 milliseconds at 120 mg, but at a much higher dose, 600 mg, it only lengthened by 4.6 milliseconds. Higher dose, smaller effect, that's genuinely paradoxical. And it's exactly why Maudsley still places Lurasidone in the no-effect QTC category despite that isolated finding. If a question tries to trip you up by implying QTC risk rises with dose here, the trial data says otherwise. Before we go through the list, know the frequency bands themselves because MRC Psych tests these definitions directly, independent of the drug. Very common means 10% or more, common is 1 to 10%, uncommon is 0.1 to 1%, rare is 0.01 to 0.1%, and very rare is under 0.01%. That's a universal regulatory convention. Learn it once, apply it to every drug you study. Now applying it here, common and very common effects center on anxiety, drooling, GI discomfort, nausea, restlessness and sleep disturbance. Uncommon effects include reduced appetite and a scatter of autonomic and musculoskeletal symptoms. The rare end has angioedema, eosinophilia and rhabdomyolysis, and frequency not known includes some serious entries. Stevens-Johnson syndrome, AV block, renal failure, rare enough that we can't quantify how often they occur but serious enough not to dismiss. Now zoom out from that long BNF list to the bigger picture, because this is where the exam angle actually lives, and this slide is where the hard numbers really tell the story. Postural hypotension, under 2%, the lowest of any second-generation antipsychotic, against 24% for clozapine and 27% for quetiapine. Sexual dysfunction, no reported cases in the cited trials compared with up to 70% for haloperidol and over 50% for olanzapine. Those aren't vague reassurances, those are real comparative figures. Its one honest weakness still is akathisia and EPS. Dose-related, real and worth counseling on, especially at higher doses. So hold both pictures in your head, a long BNF list on one side and genuinely exceptional comparative numbers on the other, with EPS as the one trade-off that doesn't disappear. Two quick but genuinely bulletproof points before we move on. First, neuroleptic malignant syndrome. It's tempting to think a drug with this tolerability profile is somehow exempt from the serious stuff. It isn't. Case reports of NMS exist with Lurasidone, and that single fact is exactly the kind of thing an exam uses to test whether you understand that NMS is a class risk, not a receptor profile risk. Second, know what this drug is not for. It has no intramuscular formulation, so it has no role in rapid tranquilization. Its slow 1 to 3 hour Tmax makes it pharmacologically unsuitable for that anyway. It has no long-acting injectable, unlike aripiprazole, paliperidone or risperidone. No orodispersible tablet either. If a question describes an acutely agitated patient needing rapid control, Lurasidone is never your answer. Remembering what a drug can't do is just as testable as what it can. Two things to lock in from this fact alone. First, case reports of NMS exist with Lurasidone, full stop. It doesn't matter how clean a drug's receptor profile looks on paper. NMS is a risk that travels with the entire antipsychotic class, not something a favorable side effect profile buys you out of. Second, this drug simply has no formulation for acute situations. No intramuscular injection, no depot, no orodispersible tablet. So if an exam question hands you an acutely agitated patient needing rapid control, Lurasidone was never a candidate answer to begin with, not because of a contraindication, but because the formulation doesn't exist. Everything on this slide traces back to one sentence from Pharmacokinetics. Lurasidone is a CYP3A4 substrate. That's it, that's the whole interaction chapter. Block the enzyme with a strong inhibitor like ketoconazole or clarithromycin, levels climb dangerously. This combination is contraindicated, full stop, not just avoid if possible. Block it moderately with diltiazem or fluconazole, and you don't avoid, you adjust, halve the dose. Induce the enzyme with carbamazepine or rifampicin, and you wash the drug out before it can work, also contraindicated. One mechanism, 3 tiers, 3 precise answers. Let's stress test everything in 60 seconds, 8 rapid-fire true or false statements, exactly the phrasing you'll meet in a single best answer question. Licensed for bipolar depression in the UK, false, that's FDA territory. Has an IM formulation, false. No rapid tranquilization role at all. Postural hypotension under 2%, true. And now you know the actual number. NMS exempt, false. Case reports exist. No antipsychotic is exempt. Moderate and strong CYP3A4 inhibitors managed identically, false. One's a dose adjustment, one's a contraindication, and mixing those up is a classic way to lose an easy mark. Must be taken with food, true. Steady state in about a week, true. Licensed for dementia-related psychosis, false. And it carries the same mortality warning as every other antipsychotic in that population. If you got all 8 without pausing the video, you've genuinely mastered this drug. If this saved you from confusing the UK and US licenses, or from freezing on the CYP3A4 interaction table, hit subscribe. This is one video in the full Dr.Psych Elite Pharmacology series, and every antipsychotic, every antidepressant, every mood stabilizer is getting the same treatment. Drop a comment telling me which drug to break down next. See you in the next one.